Hello, Internet. We are back, and I must tell you, I'm excited. We've got Dr. Eric Solomon here, and he's going to talk to us about a new look at adult life support. Now, I guarantee you, by the time we're done with you, you're going to know what to do. At the same time, I must put my lawyer's hat on. There's disclaimers. This is not supposed to be the alpha and omega on medical advice. Please go and see your own doctor, your own specialist. If you have any doubts, then just go. Don't try and sue us. We're trying to help you. I will definitely pull a Florence Nightingale on you. And for you who don't understand what I just said in legal terms, very fascinating. You could not actually sue a hospital up to about 1918. That is in the UK. And then a little bit further in South Africa, I think up to 1942. Now, they said it was a charitable institution, and therefore it would be wrong to sue such people. And you know, the English people, whether we like them or not, very fair way of thinking sometimes. And the court case which changed it was the Younger Umfolozi River War Memorial Hospital. And what happened here was, I'm sure, Eric, you will find this fascinating. This guy was a young soldier. He came back from North Africa and he had to have his appendix removed. They removed it. And would you believe, while he was still under the influence of the drugs they gave him, they packed him with warm water bottles because of he was cold. And then the bottles, they burst. And now the man suffered severe burns. And sadly, he didn't know it because he was still under the narcotics. And then, even more sadly, what happened then was he was supposed to go on honeymoon. And let us say he was a bit ruined in that sense of a word. And he was the first one who could actually sue a hospital. Jokes aside, we are here to help you. We will ask you, please leave comments, ask questions, and we will try our best to answer them for you. So thank you, Dr. Eric. Very welcome, yes, sir. Let us do this. Tell me about supporting life, saving the world.
Thanks, Chris. Always embarrassed by the fine way I get introduced on your program. I hope I am worthy of such a wonderful introduction. The adult life support is an extremely important aspect, and we all really need to know something about it. A lot of us don't know much about it. A lot of us have heard about it. We think we know about it, but we don't really understand the concept. So it's been presented on many platforms around the world for many years, and ideas have changed, come and gone, changed. Some have stayed, some have gone. But in essence, there are a few things that one really needs to keep in mind and actually become so au fait with that it becomes second nature. That you could be woken up in the middle of the night, and if somebody said to you, how do you do maintain an airway? You should be able to do it in your sleep. So that's what I really want to introduce here is the concept of how you maintain an airway, because there is nothing that is more life-consuming so rapidly than loss of an airway. So this needs to be addressed, and I'm going to stress the airway as a top priority in this talk of ours. There are other aspects that we will talk about, the cardiac massage, etc. But I want to spend most time actually talking about supporting the airway. Now, I think to make it really interesting, I'd like to share a little bit of medical physiology with you, just to let you know how things work, so the layman gets a better idea of what actually happens, and therefore, if you understand something, if you understand a concept, applying a solution to it is much easier and longer lasting. So what we really need to understand, first of all, is, why do we breathe? I mean, what's the mechanism of breathing, and why do we need to actually breathe? We have to breathe because the body's functions depend mainly on the intake of oxygen. Now, oxygen is freely available in the atmosphere, and it's only in a percentage. Its percentage, I should say, is 21% of the atmosphere. Why 21%? If it's that important, why isn't it 100%? Well, I didn't design the system, but the system will operate at sea level adequately. 21% will do the average person, will be adequate for the average person. So what's the rest of the atmosphere made up? Well, it's made up of 78% nitrogen. So why do we need so much nitrogen? Well, we don't need a lot of nitrogen per se, but nitrogen is necessary in the life cycle of plants. Without it, the plants wouldn't exist. So what effect does nitrogen have on our body? Well, first of all, it has what we call a splinting effect on the alveolus. The alveolus is the smallest little part. Now, we have a little picture here we can show you. So here we have the smallest little unit in the lung called the alveolus, and that's where the gas exchange takes place. And if you have a look at this thing, it looks like a bunch of grapes, and around it is a network of blood vessels. And the purple blood vessels are the ones that lack oxygen. They've come from the body, and they're about to pick up oxygen from these little air sacs and take it off to the rest of the body. So oxygen is vital for the body's functioning. So as I said, it's 21% of the atmosphere, and it remains 21% of the atmosphere regardless of how high above the Earth's atmosphere you are. The ratio never changes. It's just the partial pressure that decreases with altitude. So 78% nitrogen, which is necessary, I'll just repeat again, for a cycle of nature. And carbon dioxide makes up the rest with water vapor. Carbon dioxide is only 0.04% or 400 parts per million, which is not very much. So I personally don't see the importance of this so-called global warming that we are doing, but that's just neither here nor there. So if one stands still and opens one's mouth and doesn't breathe, just stands still, the air pressure outside will be the same as the air pressure in the lungs. So we need to draw air in. How do we do this? So I will just go on to the next slide here. And this demonstrates very nicely what happens, because to get air into the lungs, the chest has to expand and the diaphragm has to go down. With the diaphragm going down and the chest expanding, clearly the space that was there is now expanded. So it creates a negative pressure in the chest. This sucks air into the chest. And in doing so, with the diaphragm moving downwards, the abdominal organs are displaced as well. So if you look at anybody breathing quietly and normally, the chest and the abdomen both rise. And when they breathe out, they both sink together. When there is an obstruction, and we'll talk about where the obstruction can occur, the chest, instead of moving out, tries to suck in air, but it can't manage it because it's obstructed. So therefore the chest, instead of increasing in size, decreases in size, and the diaphragm goes down, and you get seesaw movements. And that is very diagnostic of an airway obstruction, this so-called seesaw movement. By the way, when oxygen doesn't reach the tissues, that is the definition of shock. So anything that causes oxygen not to get to the tissues, we call shock, whether it be from a heart attack or whether it be from an allergic response. Anything that diminishes the blood supply to the tissues, in other words, doesn't deliver oxygen to tissues, is considered to be shock. Now, how do we make a diagnosis, first of all? Well, I think if we look at slide number 1, I've schematically drawn a picture here depicting how an airway can be obstructed. We imagine schematically that an airway is a tube. And if you bend this tube and you kink the tube can be bent that way. And that is the way that we will straighten the tube out by doing the maneuvers we will learn shortly. The other side of the picture is that if there is something in the tube blocking the tube, by improving the position of the head won't do much to that. So For the king tube, we will do the head maneuvers. And for the block tube, we will discuss shortly the so-called Heimlich maneuver to get rid of that, whatever it is that's blocking the inside of the tube. So I think this is something that one must really make a distinction between the two. A tube can be blocked either from the outside or the inside. If it's blocked by something on the inside, then it has to be forced out or sucked out. But we don't generally carry suckers with us to actually do this. So the Heimlich maneuver we'll discuss shortly as to how to do that. So we have to make a diagnosis. How do we diagnose that a patient is not breathing, or is maybe breathing but is not effectively breathing? We take a look and we listen. We look at the patient and we see maybe the seesaw breathing, which indicates immediately there is an obstruction. If there is no seesaw breathing and the patient is actually chest and abdomen are moving normally, then we know that there's most likely not an obstruction. Then we feel for a pulse. So I've got this slide here, which will indicate where the carotid pulse is in the neck. It is a very clear palpation once you get your fingers on it. And the way we do that always, for laymen in particular, is to put your fingers on the center of the throat, in fact, on the voice box, on the larynx, the trachea, and move your fingers to the side until you actually feel the pulsation. That is the carotid pulse. It's the best one to feel. And that should be an indication whether the patient's heart is beating or not. The other one I said is the radial pulse. It's the pulse on the side of your thumb, and that is also generally the best pulse to feel. There are several others, we don't need to mention them. Those are the two you go for. You clearly don't spend a lot of time looking for these things because time is valuable here and we cannot afford to lose time. So again, how do you make the diagnosis the patient's not breathing? We hear, we look and we listen. If we hear breath sounds, at least we know the patient is breathing. The breath sounds may be normal or abnormal. Abnormal, you can hear wheezing. Wheezing indicates obstruction. If the wheezing is on inspiration, that generally indicates that there is an object stuck somewhere down in the whole airway. If it's an expiratory wheeze, in other words, breathing out, that is indicative of asthma. Asthma is generally heard when the patient breathes out. He can more or less get air into his lungs, but has difficulty in expelling it because the obstruction is deeper in the chest. So the site of obstruction can be the upper airway. And here we're talking about the tongue falling backwards. Now, Chris mentioned the other day about people are worried about swallowing your tongue. You don't actually swallow your tongue because the greater part of the tongue is actually unseen. It's lying down here deep in the throat. What actually happens there is that the whole tongue moves backwards and onto the posterior pharynx, the back of the throat, and there is the obstruction. So to clear that, one has to use the jaw forward thrust. We put our fingers behind the angles of the mandible, the jaw here, underneath the earlobes. That's a classic position for it, using two fingers, as you'll see in the pictures. And we pull forward with our two fingers in the hope of pulling the entire tongue forward, displacing it off the back of the throat, allowing air to enter into. So that's the whole sort of rationale. That's the upper airway. The lower airway, well, that could be anything from blockage at the vocal cords, which is the narrowest and commonest place for an obstruction. If any food bolus gets caught there, or swelling due to bee sting or allergy or whatever it is, that's the place it's going to happen, and that's one of the most serious. Of course, if there's anything inhaled, as children sometimes tend to stick beads and stuff in their nose and their throat and so forth, these things get sucked in and can either block the trachea here or go down one side and block just one bronchus. It can be complete or incomplete. So if it's complete, you'll hear nothing at all. If if it's incomplete, then you'll hear the wheezing, which will either, as I say, if it's something obstructing the airway, will be on inspiration, but asthma generally on expiration. I think it's important to actually differentiate those two things. It's very important. You can also have a chronic obstruction. You know, people who are smokers and so forth and have destroyed these beautiful air sacs that we have there with the little networks around them. Those things get destroyed, full of mucus and unfortunately infection eventually, because it's protein in there and it's a very good feeding medium for bacteria. That can cause chronic obstruction. So as you can see, obstruction is not just a one size fits all. It's either acute or chronic, high up, low down, or intermittent, depending on the situation. I think it's very important to remember all these differences. We also have looked to see if the patients are agitated. That's one of the most common signs. You know, people who just lose their airway are immediately panic struck and impending doom. They're scared they're going to die. And I mean, it is a very serious thing. So therefore, agitation certainly is on the cards. They can have a normal color or they can be cyanosed. In other words, they've outstripped their oxygen supply and now they're in oxygen debt. They become cyanotic and they're in dire straits. They can be black. I mean, I've seen that as well. Or they can have a normal color. Or so if they, for instance, have no blood supply due to a heart attack or whatever it is, they can be ashen. So you've got a whole variety of colors taking place. And you can't just say because he's not blue or he's not this, he hasn't got an obstruction. These are the things that we have to bear in mind, the variety of what can happen. What are the causes of a patient being unresponsive? Here again, we talk about the AEIOU, and we add a C to it for the cardiac side. But so A is alcohol. Very often we find patients who've been overdoing it with alcohol, can be unconscious, they aspirate. So they're not breathing because they're drunk. Their breathing centers are insensitive. They may have aspirated food into the lungs, which complicates the matter. So that's the alcohol. The E is for epilepsy. Epileptics can present in a variety of ways. You can have a thing called narcolepsy, where the patient just falls asleep in front of you. This can happen 1,000 times in a day for known narcoleptics. Or you can have a grand mal seizure. That's the epileptic convulsion that we all know too well. And that's a guy who's going to be a little bit difficult to maintain during the seizure itself. During the seizure itself, he actually is tense, his muscles are tight, and it's very difficult to actually do the jaw forward. He may be frothing at the mouth with saliva, he may be cyanosed, he may be either unresponsive or agitated, or a combination of all those things. But he's the one that you may have a bit of difficulty in actually keeping the airway patent. Sorry, we go to I first of all. Injury, head injuries. We often, of course, will see with traffic accidents. And unfortunately, you can get a combination of things. A guy can be drunk, have an accident, or be epileptic and have aspirated. So here we have a bad combination of a lot of things happening all at once. Opium is the O, opium and other drugs. Unfortunately, today, drugs are becoming more and more important as far as having to resuscitate people, because people are overdosing tremendously today. Before it was just with alcohol and with opium or heroin or cocaine and so forth. But today, the most dangerous of all virtually is this new influx of is fentanyl. Fentanyl is incredibly powerful drug, should only be used by anesthetists and the likes. We used to use it under strict control because these patients have to have their airways maintained and guarded when we use the drug, because patients stop breathing. Now, of course, this drug is coming out in a patch form on the skin for pain, and drug addicts are scrounging the dustbins looking for the stuff, and it's becoming a major problem. But it's also coming in across the borders in America and is causing havoc with the youth today. So opium and other drugs. And then the U is uremia and other metabolic conditions such as diabetes. These are conditions that you will not diagnose as a layman when you get to a patient, but I'm just giving you this as for completeness' sake. And then the last is a C, cardiac reasons for patients being unresponsive. A cardiac arrest due to either coronary artery disease or myocardial infarction or an allergic response, a bee sting. Some people are even allergic to kiwi fruit, peanuts. Today, anything can cause anaphylaxis, which means an acute allergic response, which can lead to cardiac arrest. So those are all the things we look for. The cardiac arrest, you will try and feel for a pulse, as I said, that you do early, but you don't waste time if you can't feel a pulse, because the patient may actually have a pulse, may have electrical activity, but you can't feel it. Don't waste time looking for things. If you think that the patient's heart has arrested, you carry on with the cardiac massage. But here is where we're going to spend a bit of time on, and I've got the pictures lined up for you there. You'll see in this first picture, for maintaining the airway, this picture is perfect for demonstrating exactly what the position is for maintaining an airway. It does three things. The head is extended backwards, as you can see. There is a pillar underneath the neck, which flexes the neck forward. So the head is extended backwards, the neck is flexed forwards, and the jaw is brought forward very nicely. Without using force generally, either one can put one's finger underneath the mandible this way, and if that's inadequate, then the two fingers behind the angle of the mandible underneath the earlobes, pulling forward, as we will also describe in this picture here. On the skull, you can see the red arrow pointing in the direction that the pressure should be applied to the jaw. This slide that I have over here is important because it indicates the axes. You can see the top half of the picture shows you when a patient's head is not in the correct position. Those lines of axis that the anesthetist or whoever's managing the airway, the lines themselves are bent. Whereas the bottom part of the picture, clearly with the head extended back and the neck flexed, you can see immediately that the line of vision from anybody looking from the top into the airway is straight. So that's some more proof that this is the ideal position to sort of be in. So what do we do if we suspect a neck injury? And as we can see often on the rugby field today, a suspected neck injury, immediately somebody lies and stabilizes the head so that the neck is not moved. So how do we actually bring the jaw forward now if we're not going to be able to extend the head, flex the neck? What do? We stabilize the head, but we do a jaw forward thrust. In other words, we may have to use quite a bit of force to bring the jaw forward because this is the only thing we have left now. We can't extend the head, we can't flex the neck. So we thrust the jaw forward. And in doing so, we are hoping to pull the whole tongue because, as I said to you, the largest part of the tongue is you can't see. The part that you see, the tongue is very small. So the whole idea is to bring that whole unit, the floor of the mouth, forward by forcefully thrusting the jaw forward. That is what we will do. And one will have to work pretty hard if you are alone at this stage, because we haven't even started yet with the cardiac massage. Something that is important to mention, and I like the introduction that the NSIR use in their site, and I think Chris has put their site on the screen below. They start off with a triple H. What does that mean? Hazard, help, and a hazard, is the first one. You say hello to the patient if he responds or he doesn't respond. And if he doesn't respond, you call for help. 112, I think, is the calls in South Africa. So remember, hazard, very important. if this happens on a road or in some part where the patient and yourself are going to be compromised, and we have seen recently, so tragically, up in Pongola in South Africa, where 3 accidents occur on top of each other, and people are taken out unnecessarily by virtue of the fact that they were all in the wrong place at the wrong time. If you think that your life and the life of the patient is in danger, you move the patient. You have to get the patient away from further danger. It's pointless doing the right thing and both you getting killed. So hazard, hello, and help. Those are the 3 things. Once you've done all that, we start with the ABC of resuscitation. And that's when we start with the airway first. First and foremost, we just make sure, and often that's just enough. If the patient's had a cardiac arrest now, obviously he's got no heart rate, he's got no heartbeat, he's not going to be breathing. If a patient is breathing, his heart is pumping. I've never yet seen a patient breathe and he hasn't got a heartbeat. So, you just need to know. We talk about giving 2 emergency breaths and then starting with cardiac massage. Again, I'm going to just mention this briefly because, as I say, the NSRR and others do it very, very clearly, and they show you how they do it. But the idea is to put the heel of the one hand on the center of the chest, the heel of the other hand on the chest on the other hand, and then from above the patient with straight elbows, you compress the chest to a depth of about 4 to 5 centimeters. In good old days, we used to say you're not doing it well if you haven't fractured ribs, but it's not a good idea to fracture ribs because fractured ribs can puncture the lung and complicate the whole sort of process. So we don't want to do that. But we do want to compress the heart between the breastplate, which is the sternum, and the vertebra. And I'll show you this beautiful picture here of where the heart is actually lying. It's centrally placed, so it gives you a very good idea of where you actually have to do the compressions. We use a rate of about 100 a minute, and the generally accepted ratio between breathing and the heart rate is about 2 to 30. If you are doing this alone, it is extremely tiring. I warn you, try not to do this for as little for too long without help. This is a situation that 2 or more people are needed to actually try and resuscitate somebody. You need to have somebody either to do the breathing, and again today it's a little bit of a contentious business with COVID, and a lot of people are not really prepared to go with mouth to mouth. Hopefully there are airways available. One can be lucky. I have been lucky in the past in the public domain that equipment was available, but it's generally not that sort of equipment is generally not available. So we continue with the straight arms and compressions of the chest until help comes. Again, I just suggest that you have a look at the pictures of the NSRR or any other site that you think is fine. Now, if we go back to our first slide, the one we think about, the tube being bent or having some foreign body in it, we're now going to deal with the tube that has something in it. This is the indication, and generally you will find this if you're sitting at a restaurant or busy eating at home, and a child or an adult inhales something, or the food goes down the wrong way, and all of a sudden blocks the airway, and it generally happens in the area of the nasopharynx and around the vocal cords. We will then, if you have a look at these 2 slides there that we put up with the Heimlich maneuver, you get behind the patient, and generally the patient should be standing at this stage, and you go behind the patient and you place your hands around the patient's upper abdomen with the idea of increasing the intra-abdominal pressure, which will then force the diaphragm back up, hopefully compressing the lungs and forcing that bolus of food, generally a bolus of food, if it's going to be in a restaurant, and not necessarily always a big bolus, by the by, forcing this outwards. There you can sort of see the two positions of where you stand behind the patient and where you place your hands. The Heimlich maneuver is an extremely useful maneuver. There are also places in the world that advocate slapping the patient on their back. This is not accepted internationally, and so I don't actually consider it to be important. I think the Heimlich maneuver itself is vital, though. So that's really all we need to say about that. But I want to also introduce the concept of the automated external defibrillators, because this is a concept that has been around for a long time, has done a lot of good work, but not everybody is au fait with it. And a lot of people indeed are scared of possibly using this. So I want to demystify these AED, these devices for everybody to be able to actually approach them and not be scared, because they are very simply, it's a pretty involved bit of machinery, but it's designed so that we don't really need to understand it. We just need to be able to read and count up to 3, because the manufacturers of most of these, and there are a lot of manufacturers, have brilliantly condensed it into something that the average layman can utilize. Now, these are ubiquitous. They're all over the place. And they're in cities, they're outside of cities. I went hiking recently with my wife and dog, and we found one of them in the most remotest of places. I mean, it's quite amazing where these things are found. So I just want to tell you, this is, if you look at the 2 slides we have here, that is the international sign for these defibrillators, these automated external defibrillators. If you see that sign, you know that there is one close by and in very close proximity. The other picture I've shown you, you will be instructed by the machine to put those 2 electrodes onto the patient in such a fashion as you see illustrated there. Now, how do you know when to use this thing? Well, you don't. The machine will actually tell you. The machine has been programmed to tell you, and it in fact knows exactly what you are doing and waits for you to do command number 1 before it actually gives you command number 2. It will not give you command number 2 until you've done command number 1. Now, by virtue of its name, it's an external defibrillator. What does that actually mean? Now, we often use these machines in anesthesia and in medical wards, of course, to cardiovert a patient or to defibrillate a patient. These are not cardioverters. A cardioverter is something that takes an abnormal rhythm and at the right moment in the cycle will convert it to a sinus normal rhythm. This thing is just meant to defibrillate, which means that if the heart is fibrillating, in other words, acting like a bag of worms, not contracting properly, it's using up a lot of oxygen. And it's non-functional because it's not able to contract well to eject blood out. All it's doing is it's fibrillating. This is a very dangerous situation, and death is imminent if it's not reversed. This machine is designed to just shock the heart completely at that stage, in the hope that the sinus node, which is the heart's own pacemaker, will take over. And it generally can. You know, if there isn't too much damage done to the heart, it generally can take over at that stage. But there's another condition that this thing diagnoses as well, and that is a pulseless electrical activity, which means that the heart is actually contracting properly, but it's pulseless. You can't feel it because it's an inadequate sort of contraction. This machine will diagnose both of those, and on top of it, it'll diagnose a flat line where there is no activity whatsoever. Now, a flat line is not one. This machine will not suggest that you shock it, because it can only make the situation where, how can you make a situation that's already hopeless more hopeless? The fact is that if you are doing external heart massage like we described just now, there is a slight chance that you can actually get the heart to, spark up again. And so therefore, this machine doesn't want you to do that. This machine only wants you to shock the pulseless electrical activity or the ventricular fibrillation. And it will diagnose it and say, okay, ready to do it. It usually works in 3 steps. It tells you to step away from the patient for your own safety, because you don't want to be shocked. But it also wants you to step away from the patient so that your own pulse doesn't interfere electrically with the machines making its diagnosis. So again, I just want to encourage you to get to know these things, get to know where they are placed around you or near you. If you work in a building, wherever you work, make sure you know where one of these things are so that you can get to it and use it very quickly. They usually are maintained. They have to be maintained by the manufacturers as far as battery life and all that is concerned. But that shouldn't be your concern. You need to know where they are and not to be scared of using these things. So in summary, I think I don't want to say anything more other than that we now understand the composition of air. We understand why air gets into our lungs to deliver oxygen. We have a nice idea of what the airway looks like. It ends up in these little air sacs where gas exchange takes place. And we know how we bring air into the body, into the lungs, by increasing the chest, causing a negative pressure in the chest, which sucks air in. We know how to recognize normal breathing. The chest rises, the abdomen rises. We know how to recognize obstructed breathing. The chest sinks, the abdomen still rises, so-called seesaw movement. We look for color changes. We listen for sound changes. And we know that the obstruction generally can be anywhere in the airway, but mainly around the throat here. We know what the causes for an unconscious patient, AEIOU. We know that, and we know how to get on with it. We use the 3 H's to avoid any hazards, say hello to the patient, and then call for help. We get on with the resuscitation, which is extension of the head, flexion of the neck, jaw forward, which we like to do. If we suspect a neck injury, only jaw thrust forward. And then if the tube has a blockage in it anywhere, generally a bolus of food stuck over here in the throat, we go behind the patient, we do the Heimlich maneuver. And then if we're in a place where we suspect a heart attack or cardiac arrest, and we are anywhere near one of these automated external defibrillators, we know we're not going to be scared how to use the thing, because it's going to tell us very simply, step 1, 2, and 3, we'll apply it and hopefully save a life, because saving a life is saving the world.
I will never get enough of that saying, that Jewish saying, saving the world. You know, it's important, and I'm going to repeat these videos. We're not going to just run it once. We're going to run it every now and then so that more and more people can get exposed to it. And I will ask all of you, please, send this around, spread the word, and tell us if you saved a life. I would really want to know. And now I have a few questions, if you don't mind. The first is actually a statement. If you drive around in Africa, often you will see there's like a branch lying across the road. Once you see that, slow down. It means there's an accident across, you know, around the bend or wherever. That's the way these people actually warn you. I've seen it often in Mozambique. I've seen it up north as well. It seems to be right across Africa. So if you're driving there and you see this, don't put yourself into another dangerous situation. But now I want to ask you, sir, you said to us there's basically 2 ways. This air, I can call it a tube. Air tube can be bent, or there can be an obstruction.
Right.
Can they be both at the same time, sir? Is that possible?
Definitely. Look, again, of course, if you're obstructed, it means a lack of oxygen to the brain. Once that happens, you become unconscious. If you become unconscious, your head will slink forward. Like when we're sleeping, you know, we tend to obstruct the airway, and the chin will move forward and then obstruct. So sure, we can have both. And the way you approach it is always first by getting the head into the ideal position, extend the head, flex the neck, jaw forward. If that doesn't help, then we know there is further trouble. And the trouble we have to then look for.
Okay, so if a patient has a nosebleed Is it still a good thing to tilt his head back? Or should you then just use the jaw forward?
Now, look, generally a nosebleed comes from the septum of the nose, which is in the middle. It's called Little's area, and it's a site which is often the cause of bleeding, and we see this. People who stick their fingers in the nose, of course, it can happen. The septum is very thin. It's also the area which is affected with people who sniff cocaine. Now, the reason for that is that the cocaine is a very strong vasoconstrictor. It sort of causes constriction of the blood vessels, and it causes a constriction of the blood supply to the septum. And these are people that end up with a hole in the septum. And it's not very pleasant smelling. It's a problem. But generally speaking, if one has a hemorrhage from this area, and usually the Little's area, what I've always done in the past is to sort of apply compression of the nose over the Little's area and tilt the head slightly forward. Because tilting the head backwards puts us into the position of blood, again, possibly going down the back of the throat and aspirating into the lungs. Thanks for reminding me. I think we just needed to also remind people that once you overcome the obstruction and the patient's still breathing, we put the patient in this recovery position. I actually failed to mention it. And the patient in the recovery position means he lies on his side, the bottom leg that is lying on is straight, and then the upper leg is bent. So he remains stable in that position, and the jaw is still, now we're talking on the side, the jaw is still brought forward and the head is still tilted back. So that's called the recovery position. Epistaxis or nosebleeds should be handled with compression to the nose and with the head slightly forward. This will obviate that there is no blood going down the back of the throat. Of course, one must always figure out, why is the patient's nose bleeding? Is it trauma? Is it something like, for instance, inhalation of drugs? There are other diseases, of course, blood dyscrasias that can cause it, and hypertension, high blood pressure, So one has to look into what the reason for the nasal bleed is. But generally speaking, I would suggest the head slightly forward and compression of the nose, and wait at least 10 minutes. I say 10 minutes because the coagulation takes about 6 minutes, but a little bit longer would always be a good idea. If it ceases to bleed, you're fine. If it doesn't, we need to go further and seek medical help for that, as far as that's concerned. I think another thing I'd like to, that I actually left out, that I could have brought in: how long do you carry on with external heart massage? Often a question that is asked. Well, as long as you need is the answer to that. Now, how long is that? Well, again, it depends on a lot of factors. It depends on the general health of the patient. It depends on the ambient temperature. Now, bear in mind, after 3 minutes, if the patient hasn't got oxygen to the brain, the pupils will start dilating, and so we don't really have a long time. So you'd say, well, why carry on for 10 minutes? Why carry on for 20 minutes? Because the reason for that is, quite simply, in cold climates, and particularly in drownings, the patients cool down extremely fast and rapidly. So what happens there is that your oxygen needs are decreased. So if you pull a child out of very cold water, that child is possibly salvageable. And this has happened on numerous occasions, that children who've been immersed in water for maybe up to 50 minutes, an hour, can be saved, because they're using very little oxygen at the time. But there is a problem with this, because people who are exposed to cold, as their temperature starts dropping, they start shivering. And when you shiver, you use a tremendous amount of oxygen. So if a patient falls into water, as often is the case with children or people drowning, it happens very rapidly. They don't go through the shivering phase. So these are people who are still they're like dormant animals in winter. Their whole metabolism slows down, and when they're pulled out, you can still resuscitate them. So in colder climates, you can carry on for longer. But generally speaking, you carry on as long as you can, as necessary, until help comes and somebody says to you, "No, listen, we can't go any further with this."
I remember the police, they taught us when you get a drunk prisoner, which you got often, especially during your time at university, as well as on Friday nights, Saturday nights, you would turn him on this recovery position of yours because they do start to throw up. And I suppose the body is trying to get rid of this alcohol. Is that why when you're really drunk that you'll be throwing up?
Oh, well, listen, I mean, that's not the only reason. Unfortunately, the liver can only detoxify alcohol or poisons at a certain rate. You can't speed it up. That's just the way it is. There is a certain rate. I can't give you an exact figure at the moment. I used to know what the figure was, but it takes time to detoxify. And in fact, here in Sweden, a lot of people are actually caught with a breathalyzer the next morning after having had a binge the night. They know that they don't drive cars here in Sweden, and there's zero tolerance for alcohol in Sweden. So if you drive a car here and that's it, you lose your license. But the guys who are caught generally the next morning because they may have imbibed too much, and they are still busy detoxifying it by the time they go to work the next morning. So that's one of the things. The bringing up, you talk about the prisoners, that's an interesting concept because alcohol, whatever it is in excess, but alcohol, it's a gastric irritant, and eventually it just causes you to vomit because, it is such an irritant. And it's one of the ways that the body expels toxins, and alcohol is a toxin. People think it's a stimulant. It's definitely not. Alcohol is certainly, you may feel stimulated, but unfortunately, alcohol depresses your reflexes terribly, so that's a bad thing. But one of the other things you talk about, the police, I'm sure you saw, when the patient who's drunk is like sitting in a chair with his arms slung over the back, wakes up in the morning and he's got a nerve palsy of his hand because he's lying on the nerve supplied to the hand and he's unaware of it. I've seen all sorts of things as far as drunk people are concerned. I saw a person burn a hole through his hand with a cigarette. He was unaware of it. He was so drunk. The cigarette just burnt a hole in his hand. But so that's what happens.
Best thing is don't drink and don't smoke. I think that will be the message and eat healthy. But we're going to have many episodes where we're going to discuss certain issues as well as, of course, your questions. I just want to know you. I've heard somewhere that if you do CPR or heart massage on somebody who doesn't need it, that you can actually cause injury here.
Well, I don't know if that will happen because if you do CPR on somebody who doesn't need it, he'll let you know. He'll tell you he doesn't want it. Generally speaking, if you're not sure whether the patient has a pulse or not, you carry on. I mean, you do it. And if he doesn't know, if he isn't aware, he's lying there and he doesn't need it, he'll soon let you know that he doesn't want it. The fact of the matter is that when you do your investigation, you go through the 3 H's, the H is, do you hear me? Can you hear me? And if there is no response from the patient, you carry on as if he needs it. If he doesn't need it, he'll let you know. So I wouldn't worry too much about that aspect of it, quite honestly.
Yeah, we also had a thing here, so they said to us that if you really want to get a man to respond, just kneel next to him and ask him if you can have his girlfriend's phone number since he's not going to make it anyway. So I've actually seen that work. I've seen that work in the police. But now a last question to you. I've heard that a patient who's under stress like this is abnormally strong, especially if he's having a seizure. Is it possible that he can grab you there and, attack you or something?
I don't know how to answer that question because the fact is, no, look, an epileptic seizure means that there's a stimulus in the brain somewhere that's causing the motor system to contract violently. There's a lot of reasons for that. This can happen. It doesn't necessarily mean you have to have epilepsy for that sort of contraction to happen. It can happen with certain poisons. There's a lot of things that can cause it. But the contractions are incredibly strong, and they will unlikely hurt you. But I mean, the fact is, you may have to battle to actually keep an airway patent. Strange enough, the people who have the so-called narcolepsy that just fall asleep, and they fall asleep, it can be for a split second, sometimes hundreds, thousands of times in a day, they'll do it. They will, if it lasts for a long time, they are slop and relaxed. They're not like the grand mal seizures that we spoke about now that are difficult to maintain. They will be the guys that fit into the normal thing of obstructing the airway. Therefore, all you do is you extend it. Again, I want to emphasize, you don't have to make a diagnosis when you see somebody like this, unless it's obvious, unless he has a seizure. You don't have to know what's causing the seizure as long as you try your best to keep the airway going. It is your duty only to keep the airway, regardless of what caused that patient to be unconscious or to be in a state of extremis. Again, you do only one thing, and you think positively about the airway maintenance and nothing else. And that's my advice to people. Don't panic.
Can we practice this in safety on someone? Let's say we've been listening here. Can I go and grab my wife and make her lie down and
Exactly. You don't have to use force. I mean, in fact, I suggest people do this continuously. I also like, I jokingly said, but I say it in all seriousness, put a sticker on the back of your toilet door, on your shaving mirror, on your fridge, just with the three things: extension head, flexion neck, jaw forward, displacement. Put that there so that you know what's going on. You can even put the AEIOU one if you want that there as well. But the ABC of breathing, ABC of resuscitation, airway, breathing, circulation, that really doesn't tell me exactly what we're doing, but the extension head, flexion neck, and pragmatic position of the jaw tells me everything. And that is a little rhyme I just want more and more people just to learn and remember, so that you can wake up in the middle of the night and say, how do you maintain an airway? You say, extend head, flex neck, jaw forward, displacement. End of story. I promise you, it is such a vital step. And I would be very, very happy if we got feedback to say people have applied it and was successful. I taught this to my son when he was a lifesaver, and he actually saved a kid's life on the beach in Cape Town. It was very rewarding to know. So,
well, there is a Second World War link here. I don't know if the viewers are aware of that, but during the Blitz, they did put the aircraft silhouettes of a German aircraft behind the toilet doors. I mean,
yeah,
what else are you doing there besides the obvious? I mean, you can just as well read here what's going on. And I'm sure there'll be a lot of jokes.
definitely.
So thank you for this. We really appreciate you. If you have questions, please come back to us. But rather act. Don't let somebody die right in front of you. Spread this around and let us know if you saved a life and save the world.
Excellent. Thanks a lot, Chris, and we'll be in touch.